Our next speaker is Dr. Carlos Ordóñez. He's a general surgeon specialist in trauma, acute care surgery, and critical care, associate professor of general surgery, trauma, intensive care at the University of del Valle, in Fundación Valle Lili in Cali, Colombia, and chief director of the trauma and acute care surgery at the Universidad del Valle, and was promoted as the chairman of the Department of Surgery of the Universidad del Valle, Hospital Universidad del Valle in Cali, Colombia. Dr. Ordóñez has 25 years experience as trauma surgeon and critical care specialist, and he is co-investigator and collaborator with the University of Pittsburgh on international training and research in trauma. Dr. Ordóñez is a member of Pan American Trauma Society and is currently the president of the society. He is also the director of International Trauma Registry of the Pan American Trauma Society as well. He is a member also of many distinguished societies such as American Association of the Surgery of Trauma, World Society of Abdominal Compartment Syndrome, and Colombian Trauma Society and World Society of Emergency Surgery. He holds leadership positions in many of these organizations, and he's a frequent presenter at WST meetings, and is prophylactic author of scientific reports of clinical investigations. Thank you, Dr. Ordóñez. You want to talk us about CT in hemodynamically unstable patients, how is unsafe?
Good morning. We're going to be speaking about computerized tomography in hemodynamically unstable trauma patients with penetrating and blunt trauma. Is this safe or not? Some of the photos yesterday some of the same slides from yesterday to insist that these are our patients. And the question is, these same patients that we looked at yesterday, we need to decide, do they go to surgery or do they need scanning first? So we divided the group into three to have greater clarity. The truly unstable patients, they have systolic blood pressure of 60 or under, so they are in cardiac arrest. They have unstable patients, but they have a systolic blood pressure of 80 or 90, and we believe that almost all of these patients should be studied first before being operated. And a third scenario, which we won't spend time on, is that yes, there are firearms or stab wounds, but the patient's stable. You need to take two decisions. Do you study them or do you operate on them? But we won't speak about that today. So the first scenario is systolic under 60 in a cardiac arrest situation. You operate on them. But if they're very unstable, they go to an interventional suite. You need to have a trained trauma team to make these decisions on whether you will operate on these patients, and you'll have help to decide which of all the wounds that you'll be dealing with. First of all, you have a ultrasound, and an ultrasound will help you decide where to operate. If there's a lot of blood in one of the cavities, we always have these in the emergency department. We put catheters for the arterial and the venous catheters. And once we have the catheters installed and we've done the ultrasound, then we decide, is this person being operated immediately or do we need additional scanning to help us? So how did we base ourselves on this? There's a lot of literature to see if the whole body CT or selective CT, and in this Trauma Journal article from 2014, they call for whole body CT, then selective CT. So not just of the abdomen or of the chest, but of the whole body. And the conclusion is that the whole body CT means that there's less fatality and less operative procedures. I thought this article was the most important from the German journal. You can look into it in detail. There's two curves, the one in the red and the black curve, and the systolic blood pressure. When a patient has normal systolic blood pressure, 120, 140, compare the red and black lines. Or with systolic blood pressure between 90, 100, who are moderately unstable, or those who are at 60 or 70, which are very unstable. And the line in red is when you do a whole body scan, and the red and the black line is when you do a selective CT scan. So you can see what the mortality rates are. And there's differences when it's an highly unstable, moderately unstable, or a very stable patient. So when you have a patient in one of these situations, it's better to do a whole body CT scan. Because in a blunt trauma, as we see in this image from the Germans, what are the areas? The head in 60% of the time, the chest in 60% of the time, but the abdomen has 22, pelvis 20, the neck. There's injuries in all parts. So if there's injuries in all parts, why would you do a selective CT scan? If you do the head and the abdomen, what about the chest? Why aren't you looking at that? That's not sufficient. The same article from the Germans show where should the CT scanner be located in relation to the resuscitation room. Here you see 80 meters or more than 100 meters. Because what happens? When you locate your CT scanner under 50 meters away from your emergency area, it's much better to have that situation rather than over 100 or over 200, because the room with the x-rays and the scanning material should be much closer to the emergency. Why? One thing is the speed and the other is the systems that should be in place. Here you see Dr. Cowley when he spoke for a long time about the golden hour. So what did he mean by the golden hour? And it's not just the hour, but the first few minutes, as we mentioned yesterday. The optimal time management is crucial. For every minute spent on decision making, mortality is increasing. For every minute that you wait, there's a 3% increase in death. So in the meantime, you could easily do a whole body CT scan, which takes 3 to 6 minutes. Because if you look at this, if there was 8 minutes saying, I'm going to take them to a CT scan, but on the lower image, there's not that loss of time because of the location of the CT scan room. Here you see the time of from arrival of the patient. Second column is the duration of the CT. 3 is the time from arrival up to the CT. So these are all in minutes. So if you have a protocol, what happens when a trauma patient arrives and you send them to CT, but if you don't have a protocol, look in the fourth graphic, you could spend 50 minutes in the CT, in the emergency department without making any decision. So what happens? A CT shows that there are benefits in hemodynamically unstable patients. But what are the questions we need to ask ourselves? First, can patients get a benefit from the CT? Can unstable patients benefit from this? You've made some decisions, you've got your scanning equipment ready, what can you do? A few years ago, we presented an article in the American Association for Trauma. It was published last year in the Trauma Journal. And I'll show you more in detail what it consists of. ATLS says that you cannot take specialized images or tests if the patient is not stable. The only thing that you could do is do an X-ray. This is even in the latest versions. But what do you need to do? How can you train your trauma team? Train all of them how to transfer patients to the CT scan. You can see all the people involved in this work, the RT, the nurses, the trauma experts, the surgeons, how to bring a patient. If the head position is proper or not, this is how all the patients are brought. And the head position is like this when you're doing normal scans. But in a trauma patient, is this the proper head position? No, this is something that we've been changing with the radiologists. It should go rather feet first. Why should it go feet first, as we've done with this patient here? Because if you look on the right photo, look at everything that the patient has connected to them for the scanning. They have the monitor, the ventilator. If you do it head first, it's very difficult. But if you have the head out, the patient can enter more easily. Look, the patient is going through and the monitors are outside. And this can help the patient very much. So one thing is the positioning of the head, the other thing is the positioning of the arms. As you can see in the first image, the arms behind the patient. But is that the ideal position? No. Because most patients have the veins in their, or they have a fracture in their arms. So much more difficult to enter into the scanner with the arms above their head. So maybe for a regular patient, but not for a trauma victim. A trauma patient should have their arms like this. If they have their arms like this, it doesn't interfere with anything. It might have a little bit more radiation when they go in like this, but there's no interference with the images. So we asked ourselves, is computed tomography attainable in hemodynamically unstable patients? Does mortality change? Does it impact surgical decision-making? Does it help in the surgical approach when surgery is indicated? And does hemodynamic instability make CT scanning unfeasible? We studied with the registry of the foundation, the Trauma Foundation from 2012 to 2013. It was a cross-sectional study. We brought massive trauma patients, ISS over 15, adults over 15 years of old, hemodynamically unstable, SBP of under 100, HR over 100 BPM, and RBCs over 4 units in the trauma bay. So these are highly, severely hemodynamically unstable, severely injured trauma patients. So what was the outcome? Some went straight to the operating room or the angio suite, and others went to the CT suite. How many patients are we looking at here? 171 over the 2 years. Group A, which goes right to the operating room, was 91, some for blunt and others for penetrating trauma. And Group 2, which is the CT group, had 80 patients, 43 for blunt trauma and 37 for penetrating trauma. And these went to the CT scan. Out of these, which ones were operated on and which ones weren't? And we can see how many were operated and not operated in the end. So the average age of the patients was 30 years old. 90% were male. The ISS was over 25 in all the patients. All of them had over 110 HR. The SBP was around 90, and most patients had SBP under 90. Patients received RBCs in the emergency, and the time in minutes to arrive at a decision when the patients went to surgery, it was 30 minutes. But if they went to CT, there was a 60-minute delay. So they spent 30 minutes more in the emergency for decision-making. And the mortality is the same in both groups. What were the procedures done? Laparotomy for most groups, thoracotomy, or vascular repair? What were the wounds in the non-operated? There were lung, brain, liver, pelvis injuries. What were the outcomes? None of the mortalities occurred in the transfer or during the CT scanning itself. Half of the patients were hemodynamically unstable when transferred to the CT scan. And in these cases, 54% of the hemodynamically unstable patients were able to avoid surgery. The other important element was for the surgeons. Half of the surgeons, half of the patients, or half of the surgeons knew exactly what cavity to enter into for the patients. And the mortality rates were not different for the CT scanning or for those who were directly operated. So our conclusions were that the ongoing evolution in damage control, resuscitation, and the technological advances in today's scanners provide, as well with multidisciplinary approaches, that can lead to CT scanning without any higher mortality. This can avoid surgery in half of the patients. It also reduces the number of unnecessary procedures and it optimizes the surgical approach. So it's possible that blunt and penetrating trauma victims can have a CT scan without any additional problem. So this paradigm shift, if you have an established team and a CT scanner, you can do this. And what do surgeons think about this? They think that death begins in the CT room. We've always heard this and believe this, but as things change, we believe that this impression should also change. they think about the pros and cons. So what are the cons? The time of transfer to the CT room. You need an adequate trauma team. There's also radiation damage. As we saw yesterday, that the contrast is a problem. So you need to see, well, what are the threats? As we saw yesterday, if that radiation is a problem for teams when they have over 64 or 108, but the quicker they are, the less radiation there is, and the MCVers can be reduced through a low dose. So the millisievers are decreasing and the image quality is increasing. Look at the cancer risk. If you have 1,000 patients with 13 millisievers, 1 out of these 1,000 will have cancer risk. So, if you do 1 scan a year since 45 to 75 years old, they have a 2% increase in the risk of cancer, and that's 1 WBCT a year. And with the new scanning that we're testing, you'll have 12 or 13 millisievers of radiation. So the problem isn't radiation. The danger is not having a diagnosis. That is where the mortality risk comes in. So is the scan the tunnel of death, or is it the triangle of life, which provides solutions to the patients? Where is the problem? The problem is training, and training for the team to do things better, quicker, every time in the imaging. The trauma team needs how to place the catheters for quick infusion of the contrast. That needs to be ready so that they're not looking for a vein when they're at the scan. You need to have a large vein to infuse the contrast. You need to have a team for a rapid transfer to the CT suite. You need to have the arms and the equipment positioned properly. You need to have a protocol, a very clear CT scan protocol. Here's our protocol. We need to have a scout strategy. And this is the protocol. The radiologists have identified. You do a CT scan without contrast of the head, and from the neck to the pelvis, one scan of arteries and veins of the patient. So we have a simple TC of the head, and then a one-shot TC with contrast from the neck, 40 to 50 mils of contrast. You wait 35 to 60 seconds. You inject the other measure of contrast, which will be the arterial contrast, which is 100 centimeters, and the patient goes in, and it's one shot, and you have an arterial vein from the garrotias to the pelvis, and you'll see the 2 perfect images of the arteries and the veins, all the organs, and you have your head scan. And the radiologists catch everything with this. What do you do with this? You reduce the amount of time spent in emergency because you know what you're going to do. You go to CT and you're not thinking, oh, we're sending him, are we not? You're diminishing the time spent in the CT scanner. You reduce the millisievers and the time exposed to radiation. And you end up with scans like this, which are excellent for diagnosis. So what do we do? The radiologist who is with us does an immediate reading of the scan. This helps in the decision-making process because right away you know, well, we're going to operate here, and the radiologist spends more time on the fine-cut CT scan and provides greater precision about whether something else was found. If you decide, okay, we're going to operate, the radiologist is going to give the information from the fine-cut CT scan. So what have we seen? If you have a failure in clinical diagnosis, the level of failure in clinical diagnosis of trauma patients can go all the way from 1.3 to 47%. If you're off on the clinical diagnosis, of course mortality rates increase. A CT scan increases the chance of survival by 25% in the first 2 hours after trauma. And the accuracy of the CT scan, both with the radiologists and the protocols, is almost at 100% in certain cases. So we do a whole body CT scan to all severe trauma patients with blunt and penetrating trauma, and with these scans, 1 out of every 4 lives are saved. What do you need for this? You need training, you need availability of the CT scanner, indications, how to interpret images, how to reduce time, a standardized protocol, and head and arms position. We know that for trauma, 1/3 of patients die on the scene, 1/3 are saved without advanced trauma care, but 1/3 of patients need help. They're unstable. They need advanced trauma protocols to be saved. And we need to work towards this. One of the possible tools we have with this is the CT scanning. Of course, we have the discussion, do we scan everyone? No. With patients with less severe trauma, ISS under 15, we need to be more selective. Reduce the number of scans and not do whole body CTs. We could scan just the pelvis, the head, but those who have ISS over 15, severe trauma, they should have whole body CT scan. So we need to standardize the protocol in emergencies and in imaging. You need to train people, you need to measure the outcomes and optimize the results. Don't be afraid of resuscitating the patient during or in the WCT suite. Everything can be done on site. Before we thought that scanning was really a tunnel where no one can go in there. No, you can optimize and work on the patient in that room. I'm going to repeat what Albert Einstein said yesterday, what we saw yesterday. If you want different results, don't do the same things. Thank you very much.